so much. Field epidemiology experience has been a growing one for me. Before the training, I've been a medical officer in public health, seeing patients one-on-one at the clinic. But the more I see, the more they come. The more I see, the more they come. And I keep wondering, the way I'm seeing these patients and attending to them, I don't seem to be very effective. It's almost like the story of a leaking roof. You keep scooping the water and trying to tidy the floor, but it keeps leaking. There needs to be an effort to get back to where the leak is coming from and see whether you can patch the leak and stop the leaking roof. All right. So that desire was there until a friend introduced me to the program, and then I got involved. I was a competitive recruitment process, and at the end, I was one of the few in my cohorts that got admitted into the program, and it's been a journey for the last 8 years for me, a journey filled with a lot of experiences, a lot of field experiences. The training itself is cumbersome and tiring, stressful, but it's worth it. I would encourage anyone that have that desire to venture into it. It's a capacity-based training. It's quite different from what you see in the conventional university training, where you sit down and have didactic lectures. It's a training that is designed to make you do. You learn by doing, and then it's also encompassing, ranging from leadership training to technical training to personal relationship training, how to work in a team, how to be able to see what's unsaid in a conversation. So it's a well detailed and in-depth training that helps prepare you for the work. The other part of the training that is very beautiful is that you are in class and at the field at the same time. In fact, you're actually more in the field than in the class. You are 25% in the class and about 75% in the field. And so during the course of the training, a lot of things changed about me, including my resilience, my ability to stay on course, being focused on the main goal, and then transform the way you look at things. Not just looking at the things at the face value, but what are the facts behind the figure. Understand? That type of training is really in depth. And the training is 2 years because this is advanced level training for us. Because the FTP is like tiered training. You have the frontline, the intermediate, and the advanced. So the one I was involved in is the advanced training. So the 2 years was both intense and exciting. The exciting part of the training is actually the field work, where you have the opportunity to be deployed with some mentors and some faculty members to go into the field, not as a layperson, but as a detective this time. Real FBI, but not in terms of pursuing a crime, but pursuing these microorganisms that cause problems to the community. Finding out where they are, where are the sources, and then using the data available in the field to be able to unveil what is hidden. So that part of field experiences is what actually was the most exciting for me. And so I would say in the 2 years of training, it was worth it. It was worth it, taking myself away from work and then being immersed full time into this training and into the field attachments that come with it. The contribution field epidemiology had made in controlling the infectious diseases and especially the epidemic-prone diseases has been immense. And then I want to draw example from two of the investigations I carried out during my training. One of them was the cerebrospinal meningitis outbreak in Nigeria in 2017. My team was deployed to Yobe State. Yobe State is in northeast Nigeria, bordering Borno State. The state is security compromised as at the time, And the outbreak has raged over the most part of northern Nigeria, which is also coincidentally part of the meningitic belt of Africa. And I was called up by Tuesday evening. Not the Tuesday evenings, and I was told that I was going to be in Yobe State the following day. So it was a challenging experience, having to decide within 24 hours to deploy to a security compromised area to investigate the outbreak of cerebrospinal meningitis, killing a lot of innocent, small under 5 children. So I answered the call as expected, and then I was mobilized. Within 24 hours, I saw myself traveling from Enugu in the southeast Nigeria to Abuja, the centerpiece of the Nigerian Federal Capital Territory, and from Abuja, take another flight to Borno. When I landed in Borno, I was transported by road from Borno for another hour, 30 minutes. I finally arrived my destination around 8 p.m. in the night, which is, in quote, a dangerous mission to move into a security compromised area in that time hour of the night. But that's one of the things we signed off to do. And when I arrived at the destination, I met the other team members who were also called up from different parts of the country. In our team, we have a laboratorian, we have a vet, we have myself, we have somebody from the Ministry of Health. It was a team of about 6-7 people. Listen, we are meeting for the first time in the field. Most of us, apart from the cohort members who are my team members, about 3 of us or 4, the other members were drawn from other parts, and they came with different experiences. And there we saw ourselves working with other partners responding to the outbreak, with the State Ministry of Health, and with all the other agencies in the field responding to the outbreak. And one thing that our training helped us to do was to try to bring all the partners together. Bringing all the partners together and have a unified coordinating unit, which is anchored in the State Ministry of Health in Yobe State as at that time. The partners involved were WHO, the MSF, and Afinet, and the Federal Ministry of Health, the State Ministry of Health, and many other partners involved in the field at that time. And what we saw was that there was fragmentation. Because of the fragmentation of data, nobody has a full picture of what was happening. So at the moment we were able to bring everybody to the table and we were able to interrogate the data, we found out that majority of the cases were not actually from where everybody thought the cases were coming from. They were coming from an isolated border community. Right? So when we were able to find where the cases were coming from, we were able to now re-strategize. And the resources were deployed to the places, more cases were identified, some were, more people were saved from complications on time, and then the cases were confined within an area, and before you know what is happening, that outbreak was brought to a control. So it is something that is very useful. Those are simple principles that we see in class of counting, dividing, and comparing, and also finding out the geographical piece where these informations are coming from, and interrogating the people that are affected and what challenges they are having to understand what is the unspoken language, what is the unspoken problem behind the scene. So when we're able to piece all this together and presented the facts before the Ministry of Health, you are very happy. You're able to deploy the minimal resources that were available to have the maximum effect in the field. So that was a very good experience for me, and we saw how, if nothing was done, that outbreak would have engulfed the whole state, right? Even though majority of the local governments in the state were affected, but the epicenter of the outbreak was a hard-to-reach community which is confined at the border. So people are reporting as if they are coming from 2 different local governments, but actually it's one community that's at the border that's where the outbreak is coming from. Notice that also that there's a difficulty accessing those communities, so vaccines are not delivered to those children as required, and then they are exposed and become susceptible to this infection. So when one person had it and brought it to the community, everybody became affected. So that was what happened in that case. The other example happened about 2018, towards the last year of my training. That was actually happened in my center. It was a Sunday morning. We were in service, and news filtered into the service that there was a death in the hospital community, and it was Lassa fever. The state is one of the states that have annual outbreak of Lassa fever. So, but when it happens and it involves a health worker, it comes with a lot of fear. It comes with a lot of emotions. It comes with a lot of problem, because people should come to health workers when they have problems. But when health workers are not dying from the same problem, it becomes a problem for the people and for the health workers themselves. So my head of department then called me out during the service and told me, Chukwuma, we have a problem in our hands. He knew I was involved in this training. He knew we had some capacity developed in the course of the training. And when he called me out, I know that the week was going to be busy. That Sunday morning, we were able to draft some plan, drop an investigation form, and then assemble a team. By Monday, first thing in the morning, the whole hospital community is already gathered, because everybody was fearful. Nobody knows whether it's a contact or not. They want a lot of answers, but a lot of questions, but answers were not forthcoming immediately. So because we already prepared ahead of time, we were able to segregate the whole hospital community into their risk categories using the risk assessment tool developed a day before. And we were able to also identify those that are high risk, quickly contact then we don't have a testing laboratory in Ebonyi State. In fact, the whole of Southeast Nigeria didn't have a testing laboratory as at that time. So the nearest testing laboratory was in the south in Edo State. So we made a contact with them that will be sending some samples across to them to help us test those that are high risk contacts. And then, so because we are prepared, we were able to manage the commotion that we're about to ensue. And immediately we segregate the cases into high-risk cases whose samples were taken and transported for testing, and then the low-risk cases who we asked to monitor themselves for any symptoms. If you notice any symptoms, they should report back, and they monitor their temperature for the next 21 days. So once those information were given out to the people as required, there was calm in the community, and the outbreak actually took a dynamic turn. But because we were there on time, within the week, a team was sent in from Abuja to join me and other team members in the state, and we were able to set up emergency operations center, an incident management system to be able to respond to the outbreak. And in no time, the outbreak was put under control, and the level of mortality was minimized. So, training and utilizing field epidemiology capacity across the country is something that no country wants to take for granted. And I believe that more investment should go into this. More people should be encouraged to volunteer themselves to be trained. And when they are trained, they should not run away with the training, but they should deploy these skills to help prevent diseases, detect diseases wherever they occur, and then contain them and eliminate them and prevent them from escalating to other places. As a epidemiologist, your contributions are immense. Actually, you are all-in-one products, depending on where the community where you are serving, depending on what their needs are. Let me draw some examples from some things that happened during COVID. Now, we are completed our training. We are in the field when COVID hits, and I happened to be in Abuja for something else, and then I was in charge of scientific communication for Nigeria. So I was in Abuja for an unrelated event, and I just noticed that I got a deployment notification to go to Lagos to respond to the outbreak. But while I was in Abuja, I was rather asked by my boss that instead of going to Lagos, that my services are needed in Abuja. And this was the early phase of COVID. We just have reported COVID in about 3 states, about in Lagos, in Abuja, I think in Kano, okay? And then, but nobody knows how the picture will evolve. And so at that point, my boss asked that we need to update our such capacity. That from what is happening in other countries, COVID was going to, the dynamics COVID was going to take is unique for each country. So we need to prepare ourselves for what is ahead. That I will hold on, another person has been deployed to replace me in Lagos. And that's how I was in Abuja. And then I was involved with a team trying to update research capacity for each of the 36 states in the country. Understand? So that was, for me, something I didn't plan for. Understand? But as an epidemiologist, you are ready for everything. Understand? So when that was going on, shortly after that, we noticed that there was a need to lock down the country. And then at lockdown, there was also need to deploy human resources to different states to contain this outbreak. So that's how I saw myself at the center of this human capacity, such capacity or update and then deployment at the same time. So we see ourselves as states are requesting for rapid response teams, because we already prepared ahead of time. You always have to anticipate a problem. Understand? So my boss and the team on ground had already anticipated that there will be a problem. And if there's a problem, we need to have people not moving across states, people being in their own state and being deployed to respond in their own state. So we need to know who was available, who was where, so that when the deployment was needed, we didn't need to start deploying people from one end of the country to the other end of the country with all the blockage that happened from state to state. So that was something that was a big contribution to our response. So we were able to respond to every state within 24 to 48 hours of their request, because there was a plan on ground. So whenever they requested, we already have people on ground who are ready to move into the area that's needed, provide the services that's needed to contain the outbreak. The other part of it is that field epidemiologists are involved in virtually everything. As I told you earlier, what I came to Abuja to do was actually scientific communication. Understand? So we are involved in scientific communication. Apart from these field works we do in the field, the field epidemiologist is able to sit down after the field work to look at the data and the experiences they had in the field, and able to synthesize new knowledge that informs public health policy, that informs new methods of intervention, and they are also improved science generally. So we see for each country, when you start your field epidemiology training, your public health research capacity is improved. Your publication output is increased, because these capacities you are training are not just there to provide services. They're also there to provide, synthesize new knowledge and to share them with the larger scientific community. And some of the early studies that were done by field epidemiologists in different countries resulted in the changes that were adapted by different countries to be able to respond to the outbreak. For instance, in Liberia, at the early stage of the vaccine introduction, the Liberian team went to the field and assessed people's opinion about the vaccine, what their fears were, and those were quickly put into communication strategy, this communication strategy, and were able to were disseminated to the people and increase the acceptance of the vaccine and the response of the people towards the vaccine. Likewise, in Uganda, in different places across Africa, we see examples wherever they have a field epidemiology training program, they're able to deploy these resources as widely as possible in different areas, not just infectious diseases, but also in antimicrobial resistant issues, in non-communicable diseases, in injuries and accidents. In every aspect of health that any country needs, be able to deploy this human resource, which are almost like all-purpose trained, to be able to solve your problem. Apart from training all-purpose field epidemiologists, you also have what they call target-specific field epidemiologists being trained in different countries, depending on their country need. The curriculum is very flexible. You're able to adapt it and deploy it as you need. And if you don't have that much money for funding a 2-year program, which is intense, you can also train lower, middle level manpower in intermediate FETP or frontline FETP, which is 9 months and 3 months respectively, and is able to give you the human resource that is able to deliver results when they are needed where they are needed. That's the key about being a field epidemiologist in the field. Thank you.